Assembly Business, Order of the Day number 1, Legal and Constitutional Affairs Committee report on the inquiry into voluntary assisted dying in the Northern Territory.
I call on the Chair of the Committee, the member for Fong Lim.
Thank you very much, Madam Speaker. Madam Speaker, this final report of the Legal and Constitutional Affairs Committee represents the best efforts of the committee to address the terms of reference provided to the committee on the 14th of May 2025 to inquire into voluntary assisted dying, or VAD as we commonly refer to it in the Northern Territory. The VAD inquiry was challenging on innumerable fronts. It was challenging in terms of subject matter, it was challenging in terms of scope, and in terms of its time frame for delivery. It's a great credit to all of those involved that the work presented in this report herein is of significant quality. It is seldom the case that reports such as this are able to capture and represent all perspectives and materials gathered and submitted. For that reason, we encourage interested parties to engage with the source materials of our inquiry in conjunction with this report, those being the many hundreds of submissions and the many hundreds of hours of witness testimony, in order to understand the breadth of the data collected and the positions presented. Notwithstanding the aforementioned, I am pleased to present this final report on VAD in the Northern Territory to the Legislative Assembly and the public at large as testament to our collective commitment to progress resolution of VAD for Territorians. In doing so, I express my gratitude, first and foremost, to my fellow committee members across the aisle and within the government, and likewise to the committee secretariat for their diligence and their respective efforts towards completing this extremely challenging inquiry. Finally, I thank again the many hundreds of Territorians who have contributed to this process and whose contributions will undoubtedly enrich our understanding of what is involved in finishing up well. Madam Speaker, VAD, voluntary assisted dying, is an extraordinarily complex topic that evokes emotion, tension, and challenges us all. It is literally questions of life and death that we are interrogating in discussing voluntary assisted dying. Ultimately, conversations about voluntary assisted dying are not just ones about fairness, they are ones about competing rights and competing tensions within our system and within our society. They are about the tension between the rights of individuals versus the rights of society, thinking about the common good, thinking about prioritising the needs of the one over the many. And sometimes lost in the debate in discussions surrounding voluntary assisted dying is that these are also questions of a tension between equity and economy. Voluntary assisted dying is more than just an arbitrary concept. It is in practice something that requires support, structures, funding, rules, governance, compliance, all of which are an essential part of creating a framework to assist people with what we once referred to as euthanasia. Euthanasia itself is a work derived from Greek terms, and it speaks to the idea of a good death. And voluntary assisted dying, the modern nomenclature for euthanasia, is in some ways an imperfect expression of the idea, but it is the journey towards providing people with the option to have a good death and equitable access to voluntary assisted dying that has driven this inquiry. Now, it's important to recognise that this is a journey that has been a long time in the making. This is a journey that did not begin 4 months ago when this inquiry commenced, but indeed starts in the Northern Territory context some 30 years ago. One could argue reasonably that the pursuit of a good death is something that goes back even further than that. But in the modern context, as many Territorians will know who have been around for decades, the Northern Territory was the first jurisdiction in Australia, and indeed internationally, depending on how you define it, to legalise an assisted death on compassionate grounds for people who were terminally ill. The Rights of the Terminally Ill Act, passed in 1995 when I was finishing high school, and I can recall the fervour surrounding it at the time, and it's remarkable that that fervour hasn't dissipated, and all these years later there are still passionate advocates for the rights of the terminally ill, both in a legislative sense and in relation to the underlying subject matter. Now, the rights of the terminally ill warrants mention as a precursor to discussing today's report because it really provides the foundation for the discussions that we are having. Some 30 years ago, the then Chief Minister, Marshall Perrin, took it upon himself to introduce to this House a bill to legalise voluntary euthanasia. He did so at considerable political cost and demonstrating great courage at the time. That bill ultimately passed, as we know, by the slimmest of majorities and not across party lines, but on the matter of a conscience vote. The final vote being one from then MLA Wes Lanhupoy, who, in his final assessment, determined that whilst voluntary assisted dying, or euthanasia as it was at the time, was not something that he envisaged his constituency or representatives, or perhaps the broader Aboriginal public, would want to avail themselves of, it was not something that he felt he should stand in the way of for the remainder of Territorians who were expressing with some clarity a desire to have legislation in the space of voluntary assisted dying. That bill was substantively about euthanasia and voluntary assisted dying, but it also represented a point of maturity and growth for this Parliament. It represented that this Parliament had the capability and the capacity to work across party lines for the greater good of Territorians. That bill signalled to the Commonwealth Government that this was a jurisdiction that was emancipating itself, that had achieved self-government in 1978, that had stabilised its polity and its representative democracy, and had the maturity to be able to prosecute complex arguments and come to a determination for what was right for Territorians. As we history students will all know, though, that bill did not endure. The Rights of the Terminally Ill Act was challenged the year after it was enacted. Only 4 Territorians ever were able to avail themselves of the opportunity to have an assisted death. And in 1996, the Kevin Andrews Bill, as it is colloquially known, a bill by a member of the then Howard Conservative government, a backbencher bill, interceded to stop Territorians and indeed subjects of any of the territories from being able to legislate in a number of spaces, but most notably in relation to euthanasia. Territorians were then, by and large, and continue to be, aggrieved by that decision, by the federal government usurping the will of the Northern Territory and the will of Territorians. That was a step backwards in our constitutional journey and our capacity to determine our fate for ourselves in relation to all of our affairs. Some 22 years or thereabouts had to pass before finally, in 2022, the Commonwealth Government was able to amend that error and pass the Restoring Territory Rights Act. That legislation was driven by members of the territories in the ACT, as well as our federal representatives in the Northern Territory, and it provided the foundation for Territorians to once again determine for themselves their own futures in relation to voluntary assisted dying. Many people assumed that there would be an immediate correction and that governments would seize the opportunity to act with haste to remedy what was an abrogation in many people's eyes of the rights of Territorians. That is not entirely how things played out, as we are aware. In the background, states of the Commonwealth, from the start of 2017, had all started to make the determination that voluntary assisted dying laws should be considered and enacted as a matter of equity and as a matter of fair access to healthcare across all states. That process began in 2017 in Victoria, where the first voluntary assisted dying legislation was passed. The passage of that bill was a rollercoaster affair. It was something that was achieved under Herculean pressure. The efforts underpinning it were not to be underestimated, and the protagonists behind the bill really paved the way for every other part of Australia to be able to gain access to voluntary assisted dying. Victoria first, followed by South Australia, West Australia, Queensland, most recently New South Wales, and then the ACT, whose legislation, whilst enacted, has still not come into full effect. Each one of these expressions of voluntary assisted dying legislation has developed iteratively, and each one of these bills has learnt from the last, to the point where now Australia has broadly coalesced around the Australian model for voluntary assisted dying. Now, from the outset of this inquiry, Old Hats to the Territory would put it to members of Parliament across of all stripes that we should simply resuscitate the Rights of the Terminally Ill Act, scrub out 1995, insert 2025, and Bob's your uncle. The truth of the matter is, this is a much more complex matter in this day and age than it was at that time, when there was a simpler regime for accessing an assisted death. For all intents and purposes, the Rights of the Terminally Ill Act decriminalised the process of assisting with a death for a terminally ill person, but lacked any of the checks and balances that are embedded into all subsequent legislation across Australia. So the process that Australia has settled on broadly for voluntary assisted dying is undoubtedly more burdensome and cumbersome than the Rights of the Terminally Ill Act was. However, it is also much more rigorous and contains checks and balances in process and procedure to ensure that what we have is something that provides Australians equitable access to voluntary assisted dying, but that we don't end up on a slippery slope argument to abrogating rights and devaluing human life. The Northern Territory government in 2023 and 4 chose to finally act on the Restoring Territory Rights Act and commissioned a report of independent experts to inquire into voluntary assisted dying and how to progress the matter for the Northern Territory. That inquiry is the basis for the inquiry that the Legal and Constitutional Affairs Committee has undertaken. The 2024 Independent Expert Advisory Report contained within it 22 recommendations for how to progress the agenda for Territorians. Our remit as a committee was to, in the first instance, interrogate the parameters of that report and to consider whether or not it could be refined, was fit for purpose, whether we might be able to add value to the equation to ensure a possible practical legislative implementation of voluntary assisted dying in the Northern Territory. We, by and large, set out on our journey not with a view to challenging the 2024 report or to codifying the 2024 report, but simply to add a body of knowledge to the 2024 report's findings, particularly with respect to the views of Indigenous Territorians and Territorians who live in remote and regional areas. The challenge had been made that in the past, consultations outside of major urban centres had been limited and that there was an opportunity for greater consultation to be done in areas outside of major cities. The terms of reference for the inquiry, therefore, were fivefold. Firstly, to provide a consultation paper to stoke the conversation again. Now, with respect to the consultation paper, we provided a 50-page document for Territorians where we simplified the issues and broadly considered the main questions of access and eligibility and process, and we did the best we could to distribute that information to Territorians across languages, in multiple mediums, in multiple forms, to provide people the opportunity to be able to be grounded in the major issues surrounding voluntary assisted dying. The second part of our terms of reference was perhaps the most important and value-adding, and that was the direction to consult extensively with people in the remote Northern Territory, to gauge views from people who may not have had the opportunity to fully provide views. The third part was to evaluate existing VAD models across the country and to some extent the world, to establish where we're up to, where we might go from here. A fourth part of the terms of reference was to consider specific challenges for the Northern Territory, noting that we have unique geography and demography and economy to consider, and that, as we are all aware, one size does not fit all, and the Northern Territory is measurably different than the rest of the states and territories of Australia. And finally and uniquely, we were charged with the responsibility, if appropriate and if suitable support was found for voluntary assisted dying, to provide drafting instructions for model legislation. Now, that final direction is extremely unusual by the measure of parliamentary inquiries. It is a rare thing to be afforded the opportunity by the government of the day to prescribe what model legislation in a space might look like. And the government is to be credited, in my opinion, for providing us with the option to not simply make recommendations, not simply provide testimony and evidence, but actually to say, this is what the VAD law should look like in the Northern Territory if we are seeking best practice and to make it work for Territorians. That final part of the process alone is many, many months of work. And the totality of the terms of reference that we were provided was, in my opinion, a huge ask of any parliamentary inquiry, let alone within 4 months. I emphasise that point to once again reiterate that it is a great credit to all of the people involved in this inquiry, the committee secretariat and committee members of the government, the opposition and the crossbench, that we have been able to provide anything and submit a report of any quality, let alone a report of significant quality. The protagonists involved in the inquiry had to work collectively, coherently, albeit in an extremely high-pressurised, challenging space, discussing extremely sensitive matters under impossible time constraints. Nevertheless, we have been able to produce something which is a document which we believe will progress the agenda of VAD for Territorians in a meaningful way, beyond simply paying lip service or, quite honestly, playing politics with the issue, which, again, I reiterate with no pun intended, is actually a matter of life and death. Now, my priority as the chair of this committee has always been to oversee a process that has been rigorous and a process that has been transparent, but not necessarily to advocate for an outcome one way or the other. I myself am not interested in dying on a hill for the issue of VAD. What I'm interested in here is demonstrating that this Parliament was able to take something challenging, as our predecessors did in 1995, and deal with it with maturity across party lines for the greater good of Territorians. And that is exactly what I think we have, by and large, been able to do. Now, what does rigour and transparency look like in the context of this inquiry? Well, in the first instance...
Pardon me.
Bless you, Madam Speaker.
Oh, thank you.
In the first instance, what rigour and transparency looks like is keeping Territorians abreast of what we are doing. We were provided terms of reference mid-parliamentary sitting on the 14th of May, and the committee wasted no time in meeting immediately to clear our calendars for 4 months, essentially, and try and establish a timetable for how to deliver this process. And that included doing things that are not often done in this Parliament, and that we did not to grandstand, but that we did to keep Territorians apprised of our work. Interim reports were presented to allow Territorians to know that we were working on this continuously. The first interim report, submitted in this Parliament in July sittings, outlined work that had been completed to date and the blueprint for the inquiry going forward, to give people confidence in the process that we were seeking to follow. The second interim report, tabled at the start of September, similarly at the conclusion of all our hearings and consultations, outlined in detail exactly where we'd been, exactly who we'd spoken to, and the parameters of our consultation, including the details of specialist advisors who we had procured to help guide our deliberations, noting that none of us are subject matter experts in this area. So those interim reports were part of the process, as were regular engagement with media and providing media releases to allow Territorians to know where this journey started, where it is up to, and where it goes next. That should be, in our opinion as a committee, the gold standard for how committee inquiries are conducted, particularly when they are substantive inquiries with heavy weighted subject matter, as is the issue of voluntary assisted dying. We've also prioritised at every stage the full and timely disclosure of submissions and of evidence. We have iteratively released for public viewing all of the 400 plus written submissions that we received, whether they were manifestos and thesis length or simply 2 lines of somebody wanting to have their say. And all of that evidence is extremely important. Now, as I pointed out, the reality is that all of that evidence will never be able to be captured in its fullness inside a report of 200-300 pages. But it is important to recognise that everyone who had a say here counts. And I say to everyone who provided a written submission to this committee that we heard your submission, we read your submission, we considered your submission. Because the fact is, we were asking for the opinions of Territorians, not for a check-in-the-box exercise, but because we are genuinely interested in what Territorians have to say on this matter. Some of it is extremely intelligent. Some of it is slightly bonkers, but all of it is really important. And that is why myself and my fellow committee members took the time to wade through the materials, to say nothing of the committee secretariat, who similarly have been drowning in VAD-related materials for months and have surfaced with a report. Now, the other thing we did to give our process rigour was not exclude the prior voices that established the parameters for the VAD agenda. To that point, from the very outset, the committee took a number of private briefings with key protagonists. The former chairs of the 2024 Independent Expert Advisory Panel were top of our list, and we are extremely grateful to the former Administrator, Her Honour Vicky O'Halloran, and also to Duncan McConnell, SC, for taking the time to help guide our journey and cooperate with us at every turn to avail themselves and to support our process without at any stage detracting from our efforts. Other key people provided significant private briefings to us in the background, including some of the key advocacy groups for voluntary assisted dying. And we took those meetings deliberately because we wanted to hear from everyone that we could reasonably hear from within a time-limited period. And so we heard from Go Gentle, and we heard from the voluntary euthanasia societies and advocates. And at subsequent junctures, we also heard from key opponents of voluntary assisted dying to ensure that we did not silence the voice of Territorians. To that point, all of the submissions that we received, the committee worked through carefully to determine in relation to what should be available to the public, what should be redacted, what should be kept confidential. And in the main, the committee has sought to provide transparency, provided that people's interests were not going to be personally affected, of course, redacting people's names and so on and so forth in submissions, names and addresses. For the most part, we've allowed people to have their say. Whether what they have to say is rational or not is for everyone to judge for themselves, or reasonable or not is for people to judge for themselves. But we wanted people to be heard, and we wanted to ensure that we provided transparency in this process insofar as reasonably possible. As I alluded to earlier, we also took the opportunity to appoint key subject matter experts as advisors. The first of those advisors was a medical, clinical subject matter expert. And so to Dr Tanzil Rahman, on behalf of the committee, I express my gratitude for helping us as people without medical clinical insight to work through challenging questions that only a subject matter expert is able to guide you with. It's a credit to her that she was able to do so dispassionately, notwithstanding that she herself was a member of the 2024 Independent Expert Advisory Panel and of course has a personal view on these matters of her own. But her input was key in helping us to understand the finer details of what is involved with voluntary assisted dying in practice. The other core group of advisors that we appointed that have provided, in my opinion, immeasurable value to this process and really differentiate the work that we have done here from some prior work is the legal advisory team that we were able to appoint from the Queensland University of Technology. Now, QUT's team was headed up by Professor Ben White, and for anybody who knows anything about voluntary assisted dying in a research or academic sense, they will know that Professor White is the Australian gold standard academic on these issues. Professor White was ably assisted by Dr Madeline Archer, Catherine Waller, Dr Katrine Del Villa and Denisha Tyler, and that group of people from the Australian Centre for Health Law Research were able to provide us with the practical legal guidance we required to turn the committee's policy positions and deliberations into quantifiable, executable legal drafting instructions. The drafting instructions for model voluntary assisted dying legislation are appended to the final report in Appendix 3. And to a large extent, they have attracted a lot of the attention because they are, in essence, the distillation of a blueprint for how to go forward from here. And it's extremely important for the sake of legislators, Parliamentary Drafting Council, our legal department within government, that we're able to provide succinct and clear guidance on what we believe as a cross-party committee is the best way forward. But having said that, they are not the full totality of the story. And so today, in the main, I won't be focusing on the drafting instructions, but on many of the other materials supporting that, including the report itself, the recommendations, and the underpinning data. My focus today, in sum, Madam Speaker, is to provide clarity. Clarity for Territorians and clarity for parliamentarians. Clarity on why LCAC, the Legal and Constitutional Affairs Committee, has made the choices that it has made. the what, if you like, of what we have done here, but also the underpinning logic of why. Because in isolation, simply reading the drafting instructions, detailed and well produced as they are, does not necessarily provide the totality of the picture of how VAD could or should work in the Northern Territory. And without being impolitic or impertinent about it, in the time since the report has been delivered, the sequence of questions that myself and fellow committee members have received from many, many, many people, the general public, our own colleagues, bureaucrats, advocates, lobbyists, all demonstrate to a large extent considerable misunderstanding of many of the issues surrounding voluntary assisted dying in practice. And so what we are looking to do here is talk about things in a practical sense and explain the choices we have made for the benefit of everyone involved with a view to progressing the agenda. Because here is the nub of the issue. In principle, support for VAD is one thing. Do you support VAD, yes or no? That's a much less complex question to ask, but a fairly imperfect one that doesn't actually progress the agenda for us meaningfully in isolation, without consideration for broader factors, without consideration for the practical, timely, without considering practical and timely implementation and how we will achieve that. If we're not careful, what we do is risk endorsing, supporting or providing a legislative solution for voluntary assisted dying in the Northern Territory that prohibits Territorians from ever realistically accessing it anytime soon. And so we've tried to make the tough choices on the curly questions, and today I'm going to help explain why we've made the choices that we've made. Now, that broader consideration that's required is first and foremost signposted and signalled within the terms of reference, within the table of contents, if you like, for the report. Going straight to the contents, you get a sense for what the priorities are and what the issues are in a broader sense here. It's not just about eligibility and whether somebody should be over 18 or under 18. There is a broad landscape and ecosystem of intersecting issues here. And so for that reason, our report begins with background to the inquiry and explanation of the conduct of the inquiry, which to some extent I have highlighted today. And then it progresses immediately to considering the intersection of VAD with existing NT healthcare, because VAD doesn't operate in isolation. VAD is another component of healthcare that has interdependencies and interactions with, most notably, palliative care, with aged care, with primary health care, with interpreters, with telehealth. There are a range of interdependencies here, and to think about VAD simply in isolation does a disservice to the whole agenda. And so we have tried, within a confined space, to consider challenges to healthcare delivery in the Northern Territory to situate the VAD conversation. We have thought about remoteness. We have considered the issue of cross-cultural challenges, noting that 30% of the Northern Territory is Indigenous, and we are the most culturally and linguistically diverse population in the country. We are ethnically, religiously, racially more diverse per capita than anywhere else. You simply can't ignore those factors when you're thinking about healthcare. You simply can't ignore those issues when you're thinking about burden of disease. And burden of disease, again, is something that plays into understandings of VAD. And as many have heard me speak about in this chamber in relation to other matters, we discuss at some length health workforce shortages. The fact is we have a shortage of healthcare workers, whether we are talking about doctors or nurses or allied healthcare practitioners or patient care assistants or translators or liaison officers or Aboriginal healthcare workers. So we have a strange system with a finite amount of staff. We don't have standalone service delivery in a range of areas. We don't have a specialist standalone paediatric setup or cardiology setup. It's important to recognise that this is a new component to the healthcare system, and if we want to introduce it, it has to work alongside what we have and not come at the cost of what we already have as well. And so we consider the interface with existing health services. We consider aged care services. We consider mental health care services. We consider disability services. And we consider Aboriginal medicine belief and practices as well, noting our unique demography. Now, that's a lot of content to cover in 20 pages in one chapter, but it's indicative of the scale of the task here that we've been tasked with. And again, our report in the main is geared towards providing practical instruction for how to move a legislative agenda for VAD forward. But to do so in isolation would be negligent and, in the committee's considered opinion, deleterious. We move on from thinking about intersection of VAD with the existing NT healthcare system to then thinking about the phrase that we landed on that resonated most profoundly for Territorians across the width and breadth of the Territory. Finishing up well. Finishing up well. We found time and time again that there was resistance and baggage associated with the word euthanasia, which is now a dated word for some people, beloved by some, hated by others. We found all manner of resistance towards the nomenclature VAD, or Voluntary Assisted Dying. Some people simply didn't like the terminology and felt that it itself detracted from the compassionate and decent side of what providing a good death was all about. But when we talk to people, particularly in our remote consultations across the Northern Territory, about providing people with help and choice to finish up well, people nodded their heads in profound agreement. The fact is, we are all, for all of our differences, human, and no one, anywhere, particularly, wants to die a bad death, a painful death, a lonely death, an isolated death, a death, embedded in suffering. And to that extent, we considered what it means to finish up well. What medical treatment provides in this space, what pain relief provides in this space, palliative care, palliation, palliative sedation. We considered a natural death and the testimony we'd received from so many places about people who stoically want to die unaided by assistance, even with great suffering. And extremely pertinently for this inquiry and this place, we considered finishing up on country. Finishing up on country, which was of profound importance to huge numbers of Indigenous people, wanting to connect to place, wanting to have the opportunity and the provision and the support to be able to not die in a hospital bed in an urban centre 1,000,000 miles from the place that you are connected to culturally, spiritually, practically. And finishing up on country, as a result, had to be mentioned with care and detail in our report. End-of-life choices vary, and we had to explore to some extent palliative care, of course, but also the idea of withdrawal from treatment, because the brutal reality of it is that not every community in the Northern Territory is New York City. There are profound capacity deficits, service deficits, workforce shortages across the Northern Territory, and it's simply not possible to provide the full suite of services and opportunities in many places. But I return to the fact that, by and large, people don't want to die a painful death, and for the most part, they would prefer to be surrounded by loved ones in a place where they feel that they would wish to pass on. But it's an unreasonable expectation for most to be asked to withdraw from treatment, to finish up on country, unaided with assistance and any of the tools of modern medicine to help you with pain relief, to help you to pass on in a peaceful manner. And so we had to wrestle with these extremely challenging questions, these extremely sensitive matters. The committee members represented all sides of the political spectrum, and we all have personal beliefs, we all carry to some extent political baggage, we all to some extent had to work together for the greater good, and it's been challenging, but again, a testament to the entire group that we were able to find consensus positions in the main. And nowhere is that truer than in relation to our fourth chapter, service delivery models. Now, in some ways, the signature piece of the 2024 Independent Expert Advisory Panel report was Recommendation 2, which suggested that the Northern Territory should have a fully centralised VAD service delivery model. So in practice, what we're talking about is, in the interest of providing clarity about where the lines of healthcare end and where VAD starts, in the interest of prioritising cultural safety, in the interest of not confusing people interacting with the healthcare system, that we might have a fully standalone, separate VAD service. And when you dig into the nuts and bolts of what that involves, we're not talking about one doctor and one nurse on standby. There is an architecture surrounding the provision of VAD, the VAD Navigator service, centralised pharmacy services, review boards and governance, so on and so forth, all of which I'll come to in due course. A key deviation for this committee was to, on balance, decide that the best way forward for the Northern Territory in terms of providing equitable but also realistic and fast, or at least timely, access to VAD was to lean on instead what is broadly considered a community-based model, what is in fact utilised everywhere else in the country to a large extent. Now, I'll provide just a small amount of definition to that before I speak about it at length later. The Northern Territory has some 1,400 doctors, give or take. We have, per capita, more doctors than anywhere else in the country, actually. Something like a metric of 5.2 or something versus 4 point something or the other for the rest of the states and territories. But we know, because of our unique demography and geography and burden of disease, that that's still not enough doctors. That's still not enough doctors to manage our specific healthcare challenges. And so the idea that introducing a couple more to stand alone separately from all of that would be able to manage this process for a finite number of people who might avail themselves of the service at a considerable cost is unrealistic and not a pragmatic outcome in our view. And on the basis of that, we have advocated to deviate from the 2024 report in suggesting that we should be utilising the full network and tapestry of our service providers, including private healthcare practitioners who provide primary healthcare some 2/3 of the time. In essence, we want to basically make use of our existing structures, and we want to make use of our existing network of healthcare providers to allow people embedded within the healthcare system already who choose to participate with voluntary assisted dying the opportunity to do so. We subsequently moved on in our report to purposes and principles, which are often glossed over and not actually articulated clearly. What is the purpose of this report and the underlying legislation? What are the principles that underpin why we are doing this? I'll come to that in detail shortly. From that point onwards, the report becomes technical and substantive and gets, if you like, into the guts of some of the things that we turn our minds to usually when we think about VAD straight off the bat. Eligibility requirements, broken down into voluntariness, medical conditions, residency, age, capacity. Request and assessment process, the actual process that is followed now for VAD, the flow diagram, if you like, of what happens and then what happens next and what happens after that and how many days do you have to do this and where do you get the drugs from, all of that business. And so we will go through the assessment process in relation to requests, formal requests, the use of interpreters, the use of telehealth. The administration of the VAD substance is a not insignificant issue, which is the focus of our 8th chapter. And that issue, let me be clear, this is the kind of thing that won't be in the report. That issue single-handedly almost derailed the Victorian effort to enact VAD legislation. At the 11th hour, questions about, hang on, safe storage and supply, where is this going to be? Who's going to have the lock and key? How is that going to operate? These are the real nuts and bolts questions that you need to consider when you're considering legislation for VAD, implementation of VAD, realistic and timely access for Territorians to VAD. There is then, of course, also the question of what happens after a person dies. There are questions there to be resolved as well, including the notification of death, interactions with the coroner, and so on and so forth. We consider at some length health practitioners' qualifications and training, and for the most part land in the same place as the 2024 report and standards around the rest of Australia. Noting, however, that we simply don't have a ton of doctors, but nor do we have a ton of nurses. And so relying on structures that are important and leaned upon heavily in other parts of the country, for example, like nurse practitioners, is less of a priority for us than it is for other places. Put simply, our position was to land on doctors making decisions and then to extend that to doctors and nurses having the opportunity to help with the administration of VAD, if and when required, particularly on location. There is also, of course, the issue of self-administration, which has a number of curly questions attached to it, which we will go through shortly. A critical deviation then, again, for this committee in relation to past work is in relation to non-participation by healthcare workers and entities. Our committee has broadly been of the view that choice is absolutely paramount in discussions about VAD. The choice to be able to access VAD as a patient, the choice to be able to conscientiously object if you don't want to be involved in the process as a healthcare worker. That's not to say that we want to frustrate the process, but in the context of competing rights, that we should be prioritising choice at all times. The choice of an individual to choose to not be involved with the process on whatever grounds they see fit. The choice for institutions to be able to also determine that VAD, if legislated for, is not something that people will be forced or compelled to have to deal with. What we're trying to provide is choice, help and choice for people to finish up well, and choice for people to be able to participate in assisting people with voluntary assisted dying if they so choose, but also the protections in law to be able to withdraw from the process if they choose not to participate. Accountability offences and protections are the kind of thing that you don't think about on the front end, but creating VAD legislation necessarily means that you have to think about all manner of other legal structures and intersections with the legal system. The review board is again a point of departure from many other states and territories. We have landed on a consensus position where we have suggested that we should make use of our existing resources, tools, structures and mechanisms. Now, when you look at the VAD data across the country in terms of the number of people that have availed themselves of voluntary assisted dying, you see that the numbers are not in the thousands, they're in the hundreds, and that's in states and territories with populations of millions. If you reasonably extrapolate to the best of your ability from that data set, all of our evidence suggests that we would expect reasonably no more than 10 to 20 people a year to avail themselves of VAD in the Northern Territory. Now, 10 to 20 people doesn't, in our mind, in the first instance, as a matter of expediency, time, equity, justify setting up huge and expensive separate structures. And that is part of the reason why we have suggested that our review board, unlike any other review board, should be chaired ex officio by default by the Chief Health Officer of the Northern Territory, embedded within the Northern Territory Department of Health, not a totally standalone separate statutory entity that will require time and significant resources to be set up and be supported in perpetuity. We recognise, of course, that that means that there is a complete and perfect separation from the health system or from direction from the government of the day or the minister. But on the balance of all available possibilities, we think that it is a constructive way forward. I note also, just to foreshadow, though I'll come back to it, that these are matters we interrogated extensively with the Department of Health in our discussions with them in public hearings on both the 5th of August and again on the 5th of September. And I want to actually take this moment to thank those witnesses from the Department of Health who spoke to us at length and were extremely honest and clear-cut with us about the practical, pragmatic reality of VAD, about what it would take in relation to implementation, about what it would cost, what the true cost would be, and what would be required to not set also the health system up to fail on poor delivery of voluntary assisted dying. I can remember them off the top of my head. I'm grateful to Chris Hosking, the CEO of the department, Dr Paul Burgess, the Chief Health Officer, Dr Kay Vella, a clinical subject matter expert and palliative care physician, and Dr Jeremy Chin, the Chief Medical Officer, as well as to Dr John Zorbas, the head of the Australian Medical Association. Those 5 individuals in particular took considerable time to report to us, both in person and in writing, to help us understand what was possible in practice. Because as a matter of equity, they all felt that people should have access to voluntary assisted dying in some form. And as a matter of equity, that is essentially the position that this committee has landed on as well. But as I say, as a matter of practice, we had to really dig into that. What was it going to cost? How are we going to do it? What is the best way forward? How can we make best use of what we have? So returning to Chapter 12, Accountability, Offences and Protections, we've had to consider the composition of the review board carefully, and I will go through that shortly. Appeal mechanisms. There must be appeal in law, rights and procedures and options for people to be able to take VAD outside of the medical process and outside of the healthcare system. And so the natural fit for that in our jurisdiction is the NTCAT, the Civil and Administrative Tribunal. And we know how overstretched the NTCAT is. We understand adding additional workload to it in this regard on complex matters that may not be entirely within their subject matter expertise or wheelhouse adds an extra layer of challenge. But we deem it to be the appropriate forum to make the subjective determinations when there are appeals processes. What if somebody doesn't quite meet eligibility requirements or residency requirements? Or what if there are problems in the formal assessment process or in reviewing documents or testimony or witnesses? None of which, of course, precludes the fact that all rights under law should still exist in terms of appeals with the Supreme Court. Creating this kind of legislation also necessarily requires you to create new offences and contravention provisions, because if you misuse or abuse the processes of VAD, it is necessary for there to be measures in law for remediation and justice, as it were. And finally, there are a number of miscellaneous provisions which we have had to address, including one that wouldn't necessarily turn to mind, which is the public education component of all of this. Very little is known or understood about voluntary assisted dying in practice by a great number of protagonists. And so it is important that whatever happens moving forward with this matter, that the government of the day continues to maintain clarity of communication with all Territorians. Many of our witness transcripts will validate that we are having an iterative discussion with Territorians about VAD, much more so than just saying, what do you think about X? Because to some extent, the question would come back being like, I don't know anything about X. I haven't really heard much about it. Tell me about it. So it's going to be extremely important for us to take into mind public education and implementation and the package of materials that were required to progress VAD meaningfully as well. Madam Speaker, I turn my attention at this time now to the goal, if you like, of this legislation. And the goal of this legislation, the goal of this report, has always been to progress the issue. That has been the fundamental goal, to progress the issue for Territorians, not to be determinative in any specific prescribed way in one direction or another. And so to a large extent, the focus has always been on the drafting instructions, the blueprint, the recipe for how to bake the cake. But the thing is, the drafting instructions are a distillation of the inquiry. They do not represent the totality of the inquiry. They do not even represent the totality of the report. On the contrary, the report has separate and specific recommendations that are detailed, a significant number of them. And those report recommendations are what I will now turn my mind to with a view to elucidating the broader issues. Madam Speaker, the report contains embedded within it and spread across the entirety of the report 80-odd recommendations. Now, the weight of my remarks today will not be to focus on those that are self-explanatory. A number of recommendations are simply put self-explanatory and do not require contextualisation. However, a great number of them do require more clarity, and so it is not my intention today to read out chapter and verse the report and submissions and data, much as I'd like to do so, but rather to provide context and establish the underlying logic and highlight the interdependencies between a great number of these recommendations, which are the next level up, as I say, from the drafting instructions in terms of explaining the what, but not necessarily always the why of how we proceeded. And I would simply say, Madam Speaker, through you to the House, that with great respect, Territorians have been waiting many decades to talk about this issue and for progress on this issue and to be heard on this issue. And so, without belabouring points, I will take my time to explain to Territorians today how we think we should move VAD forward. The report, as I say, has many recommendations, some of which marry up closely with the drafting instructions, but some of which are separate to the drafting instructions and live a level above those drafting instructions and are every bit as important to making sure that VAD in practice will work in the Northern Territory. Recommendation 1 seems harmless enough, but I can't not mention it, and that is that we recommend that the government draft legislation as per our drafting instructions to progress the agenda on VAD. So straight away, what we are saying to all of you here is that we have comprehensively looked at these issues as a committee of 5 across parties. We have delivered to you a report for the first time in living memory for some that has no dissenting reports. We have a unified position on what we think will work, challenging as it was to have to sometimes figure that out. It is comprehensive, the report, as are the drafting instructions, and more importantly, they are context specific. They are not a cookie cutter taking a bill from another jurisdiction and then mucking around with it a bit and then seeing if it will work. We are talking about creating bespoke legislation that is consistent with VAD legislation across the rest of the country and the Australian VAD model, but that is unique to the Territory, recognises our unique burden of disease, demography, geography, limitations, capacity deficits, workforce shortages, fiscal position, all of the above. So our starting gambit is to say that this committee determined, yes, there should be draft legislation to move this agenda forward. Now, why did we make that determination in the first instance? Because in the first instance, we believe that there is more than 51% and less than 100% support for VAD. We can't measure that, nor were we tasked with doing that. It was not the job of this committee to run a referendum on VAD to say X% of people are for, X% of people are against. That is now going to become the job of all parties involved with VAD going forward, to determine within individual communities and constituencies the extent to which there is support for voluntary assisted dying of a specific type, of a specific model, pertaining to a specific bill. And so I would encourage, personally, and I believe I speak on behalf of the committee, all parliamentarians to be canvassing opinion on voluntary assisted dying, not just in principle, but with some reference to practice. And in the absence of a better framework to articulate that practice, an excellent starting proposition would be Appendix 3, the drafting instructions for model voluntary assisted dying legislation in the Northern Territory. Seek opinion not just on whether people are a yay or a nay, but if what is embedded in here is something that they're on board with. The second recommendation of the report, again, at face value might look glib, might look like a little bit of a nonsense throwaway, but it's not. It's a very carefully considered thing that we've said, which is that we recommend that the government name any forthcoming legislation the rights of the terminally ill. Now, we have said that not just paying homage to Marshall Perrin or people who have come before us on this issue, but because we think that the history and the legacy of this issue should be recognised, and it should be embedded within our thinking for voluntary assisted dying moving forward. The fact is, in other places, the nomenclature voluntary assisted dying rather than euthanasia or terminally ill has taken over to provide for the possible expansion, development of voluntary assisted deaths. But in Australia, there is real clarity about the fact that voluntary assisted dying should be available not to people with dementia, not to people who lack decision-making capacity, not to people who are exclusively suffering from mental illness, but to people who are, for want of a better word, terminally ill. There is specific nomenclature for that, which is in the legal term having an advanced and progressive condition. We'll come to that shortly. But we think that it is actually significant and important to take back to the public that what we are looking to do is not resuscitate the 1995 Act, but to pay respect to it and to recognise that in the Northern Territory, we believe Territorians should have access to finishing up well through their implied and, in some ways, perhaps expressed right to, their right as a terminally ill person to avail themselves of a good death is in essence what I'm trying to canvass. So I would encourage whoever goes forward with this process to consider the importance of maintaining the focus on terminally ill persons and their implied right to a good death. Our third recommendation is an extremely significant and substantive one, which is not mirrored in the drafting instructions at all, because it doesn't, in truth, have a place necessarily in any forthcoming legislation. And that is the recommendation that government review current palliative care services and that government develop a palliative care strategy that is broader than what it has now, recognising the absolute mountain of evidence that we have that says that there is an increased need for palliative care services following the introduction of VAD. Now, if you look carefully at the testimony from September 5 and from August 5 with the Healthcare Department, you will see the clearest expression of that from our healthcare practitioners, saying that we know that we already have significant limitations in palliative care. We know that we already are stretched on all of those fronts. We know that there are many places who cannot avail themselves of palliative care properly. To introduce this, we know, will place additional strain. And so you will find robust questioning from myself of those parties to work out just how much more do we need? Just how much more will this cost? What is the real cost and workforce impost of introducing voluntary assisted dying? And again, I thank the witnesses for their clear and honest testimony. The fact is, estimates range between 10 and 30% of additional impost. Now, that level of extra effort in the healthcare system in palliative care is not something that will happen, readily or easily at a time when we are constrained fiscally. But it is a necessary thing to turn your mind to. And to give it some context, we know full well that in other states that have implemented VAD legislation, one of the common refrains of mistakes we made, things we should have thought out beforehand when we were going through the VAD process, was the extent to which they should have had both discussions concurrently about VAD and about palliative care, because Victoria probably has the best evidence of just how slammed they've been in palliative care since the introduction of voluntary assisted dying legislation. But the same could be said across every jurisdiction in the country. And so it is extremely important that as we develop this, we also turn our minds to equitable access to palliative care and appropriate resourcing of those services in a place that has significant capacity deficits and significant healthcare challenges. Recommendation 4 is the recommendation that we have made explicitly and clearly that VAD in the Northern Territory should be provided via a decentralised service delivery model, consistent with the VAD Australian model. Now, what this is about not letting the perfect be the enemy of the good. If we were flush with cash, and if we were flush with population, and if we were flush with healthcare workforce, then I would be the first one to say, in the interests of maintaining complete confidence in the healthcare system for everybody, and separation from aged care, palliative care, primary health care. We should have completely standalone division of VAD. Build the building for it. Put the standalone workforce in it. Make that the place where all these discussions can be had. But that is just not realistic. And to be clear, that's not specifically or entirely or necessarily what the 2024 report has suggested. They have simply made a clear statement that a centralised model would be the ideal and their preference, without necessarily specifying what components should be centralised and what components should be decentralised. Our thinking, as expressed in the report to some extent, but more obvious through the hours of testimony and witness hearings and lines of questioning we pursued, is that certain core components of VAD must be centralised, like the pharmacy service, like the VAD navigator service. Certain parts must be funded to succeed and maintain suitable separation, even with Chinese walls, as the expression goes, within a law firm, in relation to the review board. But there are other components of the voluntary assisted dying process that should be decentralised. We should be making use of our network of primary healthcare providers, not just in the public system, but in the private system. So that means, for practical purposes, the very many private GPs we have across the Northern Territory have the option to be able to opt in and become accredited providers of VAD services if they so choose to do so. Now, we're not suggesting that there shouldn't be, in the interest of equity, a state-based service provision of VAD. But where that is, how that happens, and exactly how that's most equitably achieved, it's too much straight out of the gate to put that entire burden on the health department. It's important that you are able to, at some point, access VAD services through the state-based health system. But we believe it's equally important and does not compromise unduly the integrity of the VAD system to utilise our existing mechanisms and focus on a decentralised service delivery model. Essentially, we've made decisions not being bean counters, not because we don't care about equity, not because we don't want people who are Indigenous or out in the bush or on a cattle station to be, it's not that we think they shouldn't be able to access VAD, we absolutely do. We just know, statistically speaking, that the majority of our, let's call them 20-odd cases a year, are probably going to be able to avail themselves of systems and services in urban centres, initially. And as we have seen elsewhere, these things develop iteratively over time, right? There has been some change in VAD legislation, although I would add to that point, individual states have found it hard, once they do something, to then reopen the can of worms and then prosecute a better VAD system. What's tended to happen is that one state has gotten this in place, and then the next state has had a better think about it, learnt a few lessons, and improved upon a few things and tweaked things, and so on and so forth. But it's still all within a tolerance of sameness of the Australian model for VAD at this point. And decentralised service delivery is also a part of that. Recommendation 5 is about the purposes of VAD, and they are quite often not articulated expressly, and it's really important that they are, because the purpose of VAD legislation is, in the first instance, to provide a lawful, legal, authorised, safeguarded process for voluntary euthanasia and for good deaths. The recommendation we have is about making sure that people have a legally authorised option to hasten their death, that we establish a lawful process, that we provide legal protections for healthcare practitioners who are in the system, that we ensure that there are safeguards, that we ensure that there is a review board to oversee the process. Madam Speaker, at this point I seek leave to table a paper entitled The Right to Die, Euthanasia and the Law in Australia by Bartels and Otlowski.
The question is leave granted? All of those opinions say aye, to the contrary no. I think the ayes have it.
Thank you, Madam Speaker. I, as many of you know, am partial to quoting the data, the science, the literature, the evidence. There's a mountain of things that I would like to bring to the table today, but that I am not going to introduce into the debate at this stage. But this one piece of literature I think is extremely useful for everyone in the House to have a flick through. And it's because it's not recent. It's because it's from 2010, and it's because from as far back as 2010, it provides a clear expression of the fact that people have been trying to get voluntary assisted dying legislation up and failing. So this predates any of the Australian setups being able to provide voluntary assisted dying legislation. It also documents the Territory's journey and the Commonwealth's intervention to nix that journey to provide voluntary euthanasia. And one of the key points that it makes contained within, which people often who are outside of healthcare practice are shocked by, is the following. That I'm going to read directly from the article here, just briefly. Under the heading, Ineffectiveness of the Criminal Law Prohibition and Risk that the Law is Brought into Disrepute. This is under the section in this paper regarding the euthanasia debate and arguments, if you like, for providing a legislative framework for VAD. I'll simply read two sentences. Quote unquote, another key argument in support of legislation is that the criminal prohibition is ineffective in practice in preventing the occurrence of euthanasia. Over the years, there has been incontrovertible survey evidence that active voluntary euthanasia is being performed in Australia, with approximately 1/3 of the respondent doctors reporting that they had at some stage provided such assistance. There's then a footnote with reference to another 10 pieces of literature just in the Australian context about doctors' practices and attitudes regarding voluntary euthanasia from 1998, about the slippery slope argument from 2002, about attitudes and practices of medical practitioners from 1994, about 1/3 of surgeons in New South Wales admitting to being involved in euthanasia practices in 2001, end-of-life decisions in medical practice, a survey of Victorian doctors from 2007, as well as the book from Magnus and Angels of Death, Exploring the Euthanasia Underground by Melbourne University Press in 2002. Now, this document I table for the benefit of everyone in the House so that we can apprise ourselves of the fact that our legislation, if it is to exist, must exist for a purpose. And that primary purpose is to provide a legally authorised framework for euthanasia, for voluntary assisted dying, for a lawful process, legal protections and safeguards, without which these practices occur and are known to have occurred, and there is empirical evidence to suggest so across all cultures, all peoples, all countries of the world. Recommendation 6, Madam Speaker, of the report is about the principles that underpin voluntary assisted dying. Again, the purpose is one thing, the principles are another. And the principles that are embedded here will not be to everyone's liking. The principles that are embedded here reflect the nomenclature of human rights acts to a large extent. And as all of you in this House will know, the Northern Territory does not have a Human Rights Act. But the principles as reflected in here are done so because they are the same principles that are mirrored in other Australian VAD legislation. I have personally argued that I believe harmonisation and consistency with legislative frameworks where possible around the country is always our best possible position to maintain, wherever that is possible. And this recommendation takes essentially that idea and puts it into practice by saying that every human life is of fundamental importance, that people's autonomy is extremely important, that end-of-life choices should be respected, that people should be provided with high-quality care and treatment, that registered health practitioners should be able to conscientiously object and be shown respect for their culture, their beliefs, their values, their personal characteristics, and within the Northern Territory context especially, that people have the right to cultural safety in relation to VAD. So it is a recommendation that I believe belongs in our legislation in some form, recognition thereof, irrespective of whether or not we have other protocols governing human rights themselves. Recommendation 7 is really about destigmatisation for some people, which is essentially to say that when people die via a VAD process, that taking that substance doesn't mean they died by suicide, but instead they are taken to have died by the disease or the illness or the medical condition that allowed them to be eligible for VAD in the first instance. And why is that important? It's important not just because of destigmatisation, but because of practical considerations and effects that interact with things like insurance and liability and death certificates, right? So it's important to recognise that when we move into a VAD space, that we provide the protections that are required for people who interact with the system, and this is another one of those. Recommendation 8, Madam Speaker, is about voluntariness and acting without coercion. Voluntariness in this whole process was absolutely paramount to our committee. Absolutely paramount. And if you look at that recommendation, it's 2 parts, which in some ways seem contradictory, but are not, because we understand where the balance of our rights and responsibilities are. We essentially say that people must be acting voluntarily and without coercion, but likewise, that in our context, especially again, a person may voluntarily request family members or other culturally important decision makers to be involved in making VAD decisions in accordance with culturally accepted practices of decision making. Now, those 2 things are not in conflict. Those 2 things are in tension, and that tension is resolved in our drafting instructions at 3.13, where we make it very clear that in the formal request processes for voluntary assisted dying, that it is the decision of the individual person who is accessing voluntary assisted dying, that is paramount. It is that person that must make a choice voluntarily and without coercion, albeit we recognise that they may do so within an ecosystem of friends, family, community, church, culture. All manner of other agents may influence the decision, but the decision remains with the individual in law as prescribed by us in this report. Recommendation 9 will have attracted attention because it is the determination that we have made on the vexed issue of prognosis, right? Now, in Victoria, when this first got up, it was a real challenge and a close-fought thing to get voluntary assisted dying legislation passed at all. And so in many ways, whilst Victoria was first, it is the hardest and most cumbersome jurisdiction to access voluntary assisted dying in. And you can literally Google, VAD, reform, suicides not working, reform required, any combination of those words, and you're going to find a lot of press as recently as a couple of weeks ago suggesting that the Victorian system requires reform to catch up to some other jurisdictions now so that people can actually in practice access VAD without being practically frustrated from being able to access the processes. And there are a couple of critical things that hold things back. And so on this particular first one, it's the issue of prognosis and timeline to death. Now, every Australian state has some combination of essentially saying, in simple terms, you must be dying in 12 months or less. In some places, it's 6 months for certain classes of conditions. But essentially, there is a timeline, a prognosis to death. The ACT, which is the most recent jurisdiction to pass voluntary assisted dying legislation, dispensed with that requirement, dispensed with the 12 or 6 month timeline on prognosis. And after much deliberation, our committee also agreed that we should concur with the ACT position. We did so for a number of reasons, but the first most important one is we spent 4 months looking at this in an extremely congested, manic, high pressurised inquiry, the ACT had a much, much longer time horizon and did an exhaustive amount of work on the issue of prognosis. And their conclusion was ultimately, in simple terms, that 12 and 6 months were fairly arbitrary and difficult to determine metrics to be able to use in eligibility. So we have not done anything vanguard. We are not ahead of the rest of the country. We are simply keeping pace with the iterative development of voluntary assisted dying legislation across the country, and have decided as a group that people must have an advanced and progressive condition which is expected to cause death, but that there is no requirement to specify whether that death will take place within 6 months or 12 months, irrespective of the condition. It's not a single standalone provision, though. The medical condition must still be causing intolerable and enduring suffering, and it cannot be relieved in a manner that the person feels is acceptable. Again, though, we have allowed for the inclusion of anticipatory suffering, which is one of the curly question issues of development in VAD legislation. And so we have noted that we recommend that suffering can also be caused by anticipation or expectation based on medical advice of future treatment or the progression of the medical condition. Now, I'm not going to speak today at any length about slippery slope arguments and the range of other, I think, weak arguments that oppose VAD, because there are actually some very good arguments in opposition to VAD. But the slippery slope arguments on this is the thin end of the wedge, and if we do this, everything will fall apart, our healthcare system integrity will fall apart, people will be knocking each other off left, right and centre. I simply don't believe that's true, and I don't think anyone in our committee believes that's the case either. And that's because there are very rigorous controls in the Australian model for VAD. Is it more cumbersome than the Rights of the Terminally Ill Act was? Absolutely. But are there better checks and balances to ensure that only people who are eligible can access the mechanisms? Absolutely as well. And so the thin end of the wedge arguments don't really carry water with us, and that is why we think anticipatory suffering is a fair thing to be able to include within advanced and progressive condition and intolerable and enduring suffering. The issue in lay terms here, if you like, for us was, what is the price of entry into the club versus what is the price of drinks once you're inside? We've set this up, if you like, so that Territorians should not be prohibited, if they are suffering and terminally ill, in simple terms, from being able to access the beginnings of the VAD process. But then from that process onwards, we maintain a high watermark for ensuring that the people that must make determinations on eligibility, on legal rigour, on witnesses, on documentation, those standards are maintained at a high level, and we have made no compromises in respect of any of that. So in simple terms, there's no cover charge to come in, but drinks are expensive. As opposed to other systems where there's a small cover charge, but drinks are cheaper. As distinct from some versions of this overseas, where basically you can get in for free and drinks are on the house. So we think that basically we've got the right balance to make this pragmatic and equitable. Now, recommendation 10 is the first of the recommendations in relation to eligibility on residency. And again, any histrionics about VAD tourism, I'm here to allay those concerns. Nobody's going to come here first. It's going to take a while for this to get set up. There are other places where this is already working, and there are other places where people will be able to avail themselves of these things sooner. And that is why we've essentially maintained the standard of 2 years residency in Australia and ordinarily 12 months residency in the Northern Territory. Now, what does that mean for somebody who is ill right now and wants to avail VAD services in the foreseeable future? I'm not going to be dishonest about it. The probability is that you will not be able to access a VAD service in practice for, at a minimum, 18 months, and closer to, at best, I would say, as a non-betting man, a couple of years. And why is that? It's because even once we have a bill, even once that bill is passed, which may yet take some months, there is a standardised 18-month implementation window that has been adopted across Australia so that health departments, service providers and the public can all wrap their heads around what needs to be done and how to do it properly. And so I have nothing but sympathy for people who are suffering right now in the Territory and are in an advanced stage with a progressive condition that is going to cause them death. But the reality of it is that it has taken time to get us to this point, and it is worth us getting this right to make sure that if and when VAD legislation comes to this House, it's the right legislation, and then it's suitable for the Territory and for Territorians, and that it means that people will be able to meaningfully, practically and consistently access these services without compromise to the greater community and polity as well. Now, it's important to note Recommendation 10 has a built-in exception, which we recognised as extremely important to make sure that people who have a strong family connection or cultural connection or support linkages for the Territory, i.e. people who might have been here once upon a time but have left, might be able to come back and avail VAD services in this place. Without wanting to be cheeky about it, the straw man that we used for this argument on all occasions was Marshall Perrin himself. We were like, all right, what if Marshall Perrin, who was a Chief Minister here, who was the architect of the initial legislation, who has a long and deep-seated connection to the Northern Territory, but for some years now has resided interstate, what if Marshall Perrin wanted to come back and avail voluntary assisted dying services in the Northern Territory? Would we account for that? Would we allow for that? Well, what we're allowing for is the process for people to be able to apply to the review board at least for exceptions and exemptions. And we think that allows sufficient flexibility to make sure people don't forum shop in our forum, but also that somebody who was connected to a cattle station or lived here once upon a time or wants to be back where their ancestral place is can come back to a place of significance to them for a voluntary assisted death. Recommendation 11 is completely uncontroversial, but I say it because it's unbelievable how many questions I've had when people are like, what will the age limit be on VAD? This isn't something that I think in our exhaustive 30 meetings and deliberations, and traipsing across the Northern Territory, I don't think we spent more than 30 seconds on this because it is a no-brainer for us that only people who are aged 18 or over should be able to access this. Now, that's not to diminish the argument. There are young people who are under 18 who suffer and who do fall into the category of people who may have an advanced or progressive condition, may be intolerably suffering, may also have the reasonable expectation of anticipatory suffering. But the Australian standard at the moment, which we have sought to keep pace with without getting ahead of, does not provision for minors to be able to access voluntary assisted dying in any form, and we maintain consistency with that position. Recommendation 12 is about decision-making capacity, and it goes to the very complex question that comes up time and time again about people who have dementia. Our same line in the sand exists with the issue of people who suffer from dementia as it does with minors. At the moment, no Australian jurisdiction provisions for people who do not have full decision-making capacity to be able to avail themselves of VAD services. Now, we recognise that a person's capacity may fluctuate from time to time, but that is a person with capacity to make decisions in the first instance, who perhaps because of illness is now fading in and out of having full capacity as they progress through the stages of the VAD process. What we have made clear is that all persons must have full decision-making capacity in relation to VAD at all stages of the VAD process. And the stages of the VAD process is something we need to discuss sequentially shortly. But Australia is simply not there yet with allowing people who have dementia and dementia alone to be decided for by other people. That may change in time. I have no personal position about it right now, beyond the fact that as a lover of the law, I believe in the harmonisation and consistency of our legislative frameworks, and this is consistency with the legislative position across the remainder of the country. Recommendation 13, again, makes clear the situation with regards to mental illness. Mental illness is commonplace, mental illness is ubiquitous, mental illness almost inevitably interacts with people who are dying. But mental illness is not in and of itself enough to be the sole basis by which to access VAD. You can have a mental illness and you can have an incurable condition and you can be eligible for VAD, but you cannot, on the basis of mental illness and malaise alone, access voluntary assisted dying. And this is one of those differentiating lines between the Australian VAD model and notably some situations in parts of Europe where people who are suffering have been deemed to be eligible for voluntary assisted dying services even when they don't have a terminal illness. So we maintain the position that people must have an advanced and progressive condition and that mental illness or disability, mental illness is not the sole basis, mental illness and disability, cannot be the sole basis for a decision regarding voluntary assisted dying. Recommendation 14 is where we begin to consider the initiation of conversations by medical practitioners. And this is an extremely important topic where other jurisdictions have essentially tangled themselves in knots by being overly restrictive in not allowing people to have conversations. As far as our committee is concerned, we believe people should be able to access information unrestricted, but that choice should always be protected. So in practice, what we are talking about here is allowing medical practitioners to initiate conversations about VAD, provided that they also canvass all other treatment options and the nature and scope and availability of palliative care services. Likewise, with the next class of people down, other healthcare workers, they may initiate the conversations where they have in fact been prohibited expressly from doing so in a number of other states. We found evidence, in fact, of the same in our own inquiries. Ex-Victorian nurses who were now embedded within our healthcare system, who specifically asked the question, will I be able to talk to people in my facility or under my care about this? I was around when they introduced this in Victoria, and it was a nightmare when we were expressly prohibited from being able to have the conversations and or refer someone and or have the conversation on a specific premise. So we have tried to work through those issues to ensure that there should be no restriction on healthcare workers being able to provide information on a topic. And to that point, we have also defined quite clearly who constitutes a healthcare worker, as well as people who provide health services or personal care services. So registered health practitioners, as well as another person who provides health services or personal and care services. Madam Speaker, the next segment of recommendations pertains to the process of VAD. And the process of VAD will be seen by many to be cumbersome, will be seen by many who are not familiar with the Australian model of VAD to be much, much too complicated and frustrating. But it is the Australian standard now. It is the Australian standard. It is essentially a four-stage process of a first request, a second request, written, formal request for the process, and then administration. It's broken down into much more fine-grained detail and steps than that, and I would encourage everyone to become familiar with the flow diagrams that are embedded within the drafting instructions to understand that better. I'm struggling to find the page now, Madam Speaker, but in any case, people will be able to find those diagrams for themselves in relation to the process that's followed. But recommendation 15 is the first place where we consider that the individual is still paramount, that a first request must be an explicit request for assistance to die, and that request can only be made to a medical practitioner. So they can make that by themselves and not by somebody on their behalf, and it must be clear and unambiguous. Recommendation 16 is about, the medical practitioner being able to choose to accept or refuse that request. And again, this is where we've embedded that people can conscientiously object because they either conscientiously object to be involved or they're otherwise unwilling. But even when they do, we have made sure that those medical practitioners are still compelled to provide patients with referral information and access to the approved information, the package of materials that would say that I can't help you with this, but here are the materials, here is the number for the VAD Navigator service, here are the people that can help you. So you can't restrict people from being able to access these services, even if you yourself as a medical practitioner choose to not participate in the process.